Good afternoon. Thanks for Chairman's kind introduction and having me in this conference. I have no conflict of interest to disclose. This is where our HIV center located in Queen Elizabeth Hospital is a regional hospital providing acute, inpatient and ambulatory service. Also secondary and tertiary care. It is government funded. There are 3 HIV centers in Hong Kong, all provide free ART. As both HIV and non-communicable disease, that is NCD, are chronic illnesses. So existing HIV care model also works for NCD care, and it also facilitates care integration. We also provide chronic disease management, which improves treatment outcome. This picture shows you the tiered approach of NCD management in our service. So we will provide NCD and risk factor screening for all people living with HIV in our clinic. We also have integrated care for NCD in our service. We also provide chronic disease management, and also we empower patients for self-care. We also have share care of NCD in the same facility or off-site for those require specialist care, such as end-stage renal failure and cancers, etc. For complex cases, we will offer case management, and we also will strengthen community care for moderate to severe disease. This slide highlighted the important components of NCD management in our integrated model, namely supported self-care to empower patients through intensive training. We also offer integrated chronic disease management through a multidisciplinary team with structured assessment and risk stratification, care planning, and empowerment. We offer case management for complex cases. We also have interface with other services, such as to strengthen the community care with our partners. I would like to use diabetes mellitus, DM, as an example of the integrated model. We will provide regular DM and risk factor screening and offer general health education to all HIV patients. When early and mild disease is identified, then we provide education on diabetes self-management, chronic disease management, and also conduct regular DM complication screening. For moderate to severe DM, so we will offer case management for complex cases, refer specialist care if necessary, and also link to community care service if necessary. The extent of NCD care integration depends on many factors, such as the efficacy of the program, service capacity, and resources required. Very often, prioritization is needed. I would like to show you the results of our cervical cancer screening program. Cervical cancer is the second commonest cancer in women worldwide, and cervical cancer is also more aggressive in HIV-infected women. And efficacy of screening program is well proven. Our program was introduced about 10 years ago. Newly diagnosed HIV-infected women have Pap smear done half yearly in the first year, then yearly after. Patients with abnormal Pap smear will be referred to our gynecologist for colposcopy. All nursing staff receive proper training, and credentialing and quality assurance are also included in our program. This is the results of our program. About 287 women with HIV were screened between 2010 and 2018. A total of 1,600 pap smear were performed during this period, and about a quarter of them were abnormal, including ascus, low seal, high seal, etc. And 88 colposcopy was performed by our gynecologists. There are 24 CIN1 and 9 patients have CIN2 and 3. And 10 interventions were performed, including lip and also hysterectomy. And luckily, we could not identify a single case of CA cervix. So the cervical cancer screening program is very effective in the prevention of CA cervix. So our center, similar to other services, face increase in workload. Apart from increased number of HIV active cases, we also have to manage NCD and mental health. So the workload is escalating. So we have set up integrated nurse clinic to sustain the quality care and also task shifting. Apart from HIV management, this nurse clinic will also support NCD screening and management, which include risk factors assessment and monitoring, NCD screening, education and counseling, disease monitoring, drug adherence monitoring, empowerment and counseling, and also refer to appropriate health disciplines if necessary. So this nurse clinic helps us doctors a lot. I will also use cases to illustrate our model. The first case is a 60 years old gentleman, chronic smoker. He is an electrician married with 1 son. He presented with PCP in 1994. After heart, the patient has sustained viral suppression. The patient also received care for NCD in our service, including hypertension, lipid, and mild chronic kidney disease. Blood pressure and lipid control was satisfactory. We also refer him for smoking cessation counseling. The patient was admitted to hospital in 2014 for acute stroke, presented with white hemiplegia and expressive aphasia. He underwent prolonged inpatient rehabilitation. Upon hospital discharge, he could walk with standby assistance. Activities of daily living are largely independent. He continued speech training for expressive dysphasia. He was put on congee diet with thickener, but still able to swallow medication. He developed biological failure in 2017 and put on boosted darunavir, atravirine, and raltegravir. And viral was suppressed after ARV switching. We also noticed that the patient's wife had carer stress, especially when the domestic helper left Hong Kong. Patient was admitted to hospital again in 2018 due to acute on chronic renal failure, and also noticed further deterioration in cognitive function and mobility. And wife agreed to arrange nursing home care after hospital discharge, but she had difficulty to find one that accepted HIV patient. Finally, the patient was admitted to nursing home in August 2018. Due to patient yelling day and night and disturbing other residents, the patient was asked to leave by several nursing homes. And we also noticed that staff crushed the tablets to ease swallowing, including some medication that are not advised to, such as ritonavir and atravirine. So in summary, this is a patient with chronic HIV infection more than 20 years, stable on ART, had multiple comorbidities, carrying and placement problem. And there are also issues of ARV related to swallowing problem. So we remind nursing home staff not to crush the ritonavir tablet, and also to monitor whether patient can swallow the tablet. And refer community geriatric assessment team to assess the patient in nursing home. I will give you more information about this service after the case presentation. We also advanced psychiatric assessment who prescribed hypnotics to the patient. After treatment, the patient had reduced agitation and yelling. Due to swallowing difficulty, the patient was eventually put on tube feeding, which also requires some modification of treatment. We changed the boosted dovinovir to boosted lopinavir solution, and other ARVs could be crushed and continue. The patient had no drug intolerance after switching, and the viral load remained suppressed. So we due to the aging and premature aging among HIV patients, we can see that the demand of nursing home care is increasing. However, in Hong Kong and in many Western countries, there are poor acceptance of HIV patients by nursing homes. And there are also barriers to engage them to training. This is the survey conducted by our service last year, which involved about 74 nursing homes, most of which are private nursing homes. We asked them the question whether their nursing home accept HIV patients admissions. And 60% of nursing home say no, and they say not ready to admit. And 24% of nursing home could admit HIV patients, but with certain conditions, such as the limit the number of HIV patients to a very small number. And only 16% of nursing home agreed to ready to admit HIV patients. When we ask about the reasons of non-acceptance, the answers are as follows: because there are no previous training, risk of HIV transmission to staffs and other residents, require higher level of nursing care, and did not want to receive complaints from other residents and their families. Based on the response of the nursing homes, we realized that there are a gap in the training to the nursing home staffs. So we are trying to enhance the community support for patients who need nursing home care. So I would like to mention about the Community Geriatric Assessment Team, CGAT, which was established in Hong Kong since 1994, aiming at helping residents to stay at the community with good health. CGAT is a multidisciplinary team led by geriatricians. So we collaborate with CGA team to strengthen the community support and also help us to organize training to the nursing home staffs. Because the CGAT provide regular training to nursing home staff. So we take this opportunity to organize training staffs. We conducted several sections of training to nursing home staff to teach about various issues of taking care of people living with HIV. The response are very good, very positive, and after the teaching sections, we also received requests of some nursing home to arrange more in-depth training to their staff. So now we move on to the second case, who is a 40-year-old gentleman, MSM, diagnosed HIV in 2012. He refused ART with frequent default and with repeated episodes of syphilis. He actually had depression before the HIV was diagnosed, but he also defaulted psyche follow-up. He lived alone, unemployed, and on disability allowance. He was transferred to our center in 2017. So counseling was offered by our nurse counselor and clinical psychologist. We also referred to our HIV psychiatric liaison clinic, which was located within our service. I will talk this service more after the case presentation. Regarding the mental health history of this patient, he had long-standing family conflicts and feeling depressed since 2009. He had marked mood swings, irritable, could not work in the past few years. The diagnosis of HIV led to his feelings of shame and hopelessness. He disliked items associated with HIV, including staff and the HIV clinic. He refused ART as he had no confidence in achieving optimal drug adherence. So this patient have a co-infection, refused ART, ongoing risky behavior leading to repeated episodes of syphilis, depression, failed retention in care, and also poor acceptance of HIV. So our psychiatrists resume citalopram and also add quetiapine for the patient, have close psychiatric follow-up in the beginning. Patients show some improvement in mood symptoms, and psychiatrists continue to titrate the medications. Patients still lack of confidence in drug adherence and worry about the emergence of drug resistance. So we continue counseling, and I also suggest the patient to try taking daily multivitamin for training to build up his confidence. He agreed, and we found that his drug adherence gradually improved. He finally agreed to start ART as a single tablet regimen in October 2018. That is 6 years after HIV was diagnosed and 18 months after the patient was transferred to our center. He tolerated ART well and missed dose only occasionally. And while low became undetectable 8 weeks after ART initiation and sustained till now. His mood disorder is also stabilized, and he was transferred back to his district psychiatric center for follow-up, and retention in care was remained. Actually, there are many literature already show the prioritization of mental health care utilization for HIV patients is justified. The results show that the results also show that it will associated with increased retention in HIV care, improved clinical outcomes such as detectable while low, and also decreased mortality risk. However, HIV-related stigma and self-stigma is one of the barriers of engagement to mental health care, and there are also other factors. So we are looking for alternative care model to address the service gap. Regarding the conventional care model, so patients are referred to psychiatric clinic after detection of mental illness by HIV physicians or clinical psychologists. The limitations include segregated and limited care coordination, high dropout rate, and no expertise to address specific issues in HIV psychiatric comorbidities. So we established a HIV psychiatric liaison clinic in 2015. It is a multidisciplinary team approach led by our psychiatrists. Our psychiatrists come to our clinic about 1 to 2 times per month. So we only refer patients with moderate to severe depression and psychotic syndrome not yet engaged to mental health service to this clinic. The benefits of this clinic is better liaison with community stakeholders, expertise of HIV psychiatry, and also better accepted by our patients because the patients are having the same environment that he feels comfortable. The limitations are require additional resources and their sustainability issue. This is the patient journey in our psychiatric liaison clinic model. After screening, the patient will be assessed by our psychiatrist in the liaison clinic, provide treatment and psychosocial management. After stabilization, the patient will refer back to district psychiatric clinics, or if the problems are in remission, then the patient will continue monitored by our HIV team. Apart from mental health, we also found that the substance use is another emerging issue in our service. We conducted a cross-sectional questionnaire survey in 2017, and we found that 31.4% participants reported drug use. 65% of them use crystal meth, and 51% use a combination of 2 or more drugs. younger age, MSM, history of STIs, and smoking were independently associated with substance use. Coexisting mental illness are common, and most drug users had never received any form of drug addiction treatment service. This slide summarizes the integrated mental health service in our clinic. We have a multidisciplinary team, including the HIV physicians, case managers, clinical psychologists, social workers, addiction counselors, and also our community partners. We regularly screen for mood disorders, substance use, and cognitive function. Counseling was offered by our CP, nurse counselors, and social workers. We have a HIV psychiatric liaison clinic. We also strengthen community care with our partners in drug addiction counseling and also community support. We also organize staff training, including motivational interviewing skills. So to conclude, there are changing needs of people living with HIV related to normal and premature aging, increased prevalence of NCD and mental health problems. Integrated care for HIV, NCD, and mental health is feasible, could improve disease outcomes, and is accepted by our patients. Barriers and facilitators of integration should be addressed. Thank you.